Thanks for inviting me, and it's really great to have a big group here. And there's a number of folks I recognize, in the audience. So it's great to see you guys again. I want to. My prepared remarks should take only, I hope, no more than 20-25 minutes, and then lots of time for questions and back and forth. I'm obviously going to talk a little bit in general first about deep brain stimulation and dystonia, but then I do want to spend some time talking about what's really new in DBS and dystonia. And the new thing that I want to tell you guys about is brain sensing and so-called adaptive deep brain stimulation. And these are functions of new DBS systems that have enormous possibilities for neuroscience, understanding dystonia, understanding how DBS works, and developing actually better stimulation treatments. All right, let's see if I can advance here. Okay, so first it's important to know, because there's always a lot of people in the audience and in this sort of presentation that is wondering, am I a candidate for deep brain stimulation, or if I've had DBS, how come I did well and someone else didn't do well, or vice versa. So I just wanted to point out that, I won't go extensively into the history of deep brain stimulation, because many of you do know that, but, ask questions if you need to. In general, though, I wanted to remind people, dystonia is a very, very broad set of conditions, and there's several broad categories, some of which already respond well to DBS surgery, and others that will respond somewhat, but not quite as well as other forms. And this confuses a lot of folks, especially when you just look up a video on the internet and wonder, why am I not like that person? So these, in the categorization of dystonia, the terminology has been changing, and actually it was officially changed in 2013 by the Movement Disorder Society. So the category that really responds best to deep brain stimulation, we used to call it primary dystonia. Now the official term is isolated dystonia. And some of the characteristics of this are typically you have a normal brain MRI in these cases. There's often, but not always, a genetic cause. There's generally a period in childhood or even throughout early adulthood where movement is normal, and then it becomes abnormal with dystonia later. In isolated dystonias, there's typically no other significant neurologic problems besides dystonia. I'll make an exception there for some mood disorders and anxiety, which can be associated with isolated dystonia. But in general, there's not a lot of other neurologic problems. And this is the category that tends to respond well to DBS therapy. The more challenging category that we nevertheless are often treating with DBS, but we're really looking for better treatments, are the so-called combined dystonia. A former name for this was secondary dystonia. And typical, just in general, the characteristics in this group are there's often an abnormal MRI scan with just abnormal signals on it. Some of the etiologies can be post-stroke dystonias, kids who have a so-called perinatal hypoxia, often called cerebral palsy. But there can be genetic causes here too in this more complicated set of syndromes, increasingly recognized genetic causes. Typically, patients in this category have some other neurologic problems in addition to dystonia, such as muscle weakness or spasticity, or in some syndromes, cognitive intellectual problems. This group as a whole is very, very heterogeneous. Some of these forms can actually respond fairly well to DBS therapy, some not so much, but in general, this is the harder category. It's the more common category than isolated dystonia, but is harder to treat, and we're still looking for better treatments for this. And then this is not comprehensive. There's other categories. I know someone in the audience is very interested in musicians, focal dystonia, which is yet sort of another area, task-specific focal dystonias. So there's other things beside this, but I just wanted you to know about these. And it's important to know, if you have dystonia, which of these categories you fit into, because the treatments are different. Before one would consider an invasive surgical therapy, there's of course a number of non-surgical treatments of dystonia, which can be quite effective. Botulinum toxin injections, it's funny that it was, now so used in cosmetic surgery, but was really developed for dystonia related problems, for blepharospasm. So for people with more focal dystonias, that is affecting a relatively smaller body part, this can really be a mainstay of treatment, and people can do very well with Botox injection. It does wear off, but about every 3 months or so, you can get this and do very well. Physical therapy in conjunction with other treatments is always a good option in a movement disorder. A number of medical therapies, so-called anticholinergic drugs like trihexyphenidyl, the so-called benzodiazepine drugs, the Valium-like drugs like Klonopin, baclofen is another one. In children with dystonia, anticholinergics actually can work extremely well. Adults don't tolerate them as well because of side effects. And pretty much in almost anyone with a diagnosis of dystonia, they should have a trial of levodopa or Sinemet, which is a drug containing levodopa. That's the mainstay of Parkinson's disease treatment, but sometimes dystonias will respond to it. So you'll know if you take it and it works or doesn't. So that's important. So when people have significant disability in dystonia that is not well treated with those other measures that I talked about, and have a clear diagnosis from a movement disorders neurologist, and have disabling symptoms, that's where you start to consider surgical therapy. We have multiple types of surgical therapy, but by far the most common and most versatile is deep brain stimulation of structures in the base of the brain called the basal ganglia. So this has been around now for a while. The first publications on this were in the late 1990s. We did, I think, our first dystonia DBS in 1999. And this, why was this done? It sort of followed in the footsteps of deep brain stimulation in Parkinson's disease. So that started first kind of in the late 80s, early 90s. And in people with Parkinson's disease, there can be dystonia as a motor problem of all their other problems in Parkinson's, right? Dystonia itself is a movement disorder sign. It's not itself a specific diagnosis. So Parkinson's patients can have dystonic problems, and DBS helped that often. And that really led people to say, okay, now let's move to non-Parkinson's people with the isolated dystonias or the combined dystonias and try DBS. And that's how it started. And it got going well before there was any notion of how it works. In fact, we still are very unclear in dystonia how DBS works. And that's actually one thing I'll talk about toward the end with the new sensing generators. For the so-called isolated dystonias, that group that has normal brain MRIs and responds well to DBS, there's excellent evidence for the effectiveness of DBS, of this structure called the globus pallidus, in the isolated dystonias. So so-called class 1 evidence, that's the highest level of medical evidence for a therapy, and that's from randomized blinded trials that are statistically valid. And here's just a couple of the big studies, both published in New England Journal of Medicine, of patients that had these very rigorous studies of globus pallidus, DBS, and dystonia, and it documented the effectiveness, resulting in in companies labeling FDA approval in the United States for DBS in the isolated dystonias. It has a category of FDA approval, a limited category, but it nevertheless is typically a known indication, accepted, and is typically paid for by insurers for this isolated dystonia category. I won't go extensively into surgical techniques, that may come up in questions, but I just broadly want to point out there are multiple methods to achieve the same end of accurate placement of a deep brain stimulator in a specific place in the brain. The oldest method, and the one that I trained on in my fellowship at Emory University, and I still do a lot of this, is using a stereotactic frame like one shown here, mounted on the head just prior to surgery. This provides a coordinate system to guide devices in the brain. Patient is, in this classical method, is awake for part of the surgery, mainly to do the physiological localization, use microelectrodes in the brain to confirm a very accurate localization, some test stimulation, that is, you activate the DBS lead while a patient's awake in the operating room, testing mainly for side effects, because the beneficial effects may take longer than you have in the operating room, but the side effects of DBS can show up right away. So you'll test it and make sure that there aren't obvious side effects at low currents. There are lots of new, or not new anymore, but lots of alternative methods for placing DBS. And one which we use quite a bit is we can place DBS leads with patients under general anesthesia inside of an MRI scanner. And the ones we use aren't in the operating room at all. They're in a radiology suite. So we pick the sort of best imaging MRI that's usually used just for diagnostic imaging, and we adapt the DBS surgery procedure to the configuration, location of that MRI. This doesn't use a frame. It uses a special skull-mounted aiming device that I've shown here below. It's just a temporary device that can very accurately aim toward an MR-determined target. In this technique, you're not using physiology or awake testing to confirm placement, but you are using real-time updated MR images of the brain and device, which is also good. We find these techniques to have pretty much equivalent risks and benefits, but the general anesthesia technique, we actually developed it for kids needing DBS because awake surgery was just not going to be a good bet for children. But there are many adults that will elect this method, and many would have great difficulty undergoing, awake DBS surgery. Some patients with very severe cervical dystonia, just impossible to keep their head in a position that is comfortable for allowing surgery awake. So the development of these accurate asleep methods has been a big thing in the last 10 or 12 years. So, while there are a lot of mysteries about DBS and dystonia, I've said we don't have a good idea at all of really how it works, but it's not really a mystery, for the isolated dystonias, the ones that respond well. We do know where to put the electrodes. So it's not, you're not hunting and pecking around and looking for the best spot. There's been a lot of studies now, and this is just an MRI of someone with these little black dots or the leads, the brain leads inside the globus pallidus, which is I'm outlining right here. And there's been a lot of studies like this where, we can accurately measure where we should be putting these leads. And we know empirically, that is just from lots of testing of leads, what are the best area? You'll look at a whole bunch of patients who have their brain leads in various different places, and you'll ask, well, who did best, and do statistical correlation. So, if you have DBS surgery, the surgeon will select the general target areas, such as the globus pallidus or thalamus or subthalamic nucleus, and then know where to target within that structure. It's not a mystery. It's important to think about complications of DBS surgery. The most severe one, which is fortunately relatively rare, is stroke from bleeding in the brain, which would occur if it's going to occur, either during surgery or immediately after. By several days after that risk is mostly gone. Over the years, we've gradually been reducing that risk. It used to be higher. I think it's now under 1% in experienced groups, just because our techniques, like any surgery, do get better with experience. Probably the most common serious problem, surgical complication that still bedevils us is hardware infection that can require, you do a successful surgery, you put in the lead, a few weeks later, an incision starts draining, purulent, you find that there's an infection under the skin around the hardware, and you often have to remove most or all of the hardware, let everything heal, start all over again months later. We've tried as hard as we can to get this risk down. It's getting better with smaller DBS hardware being available. The size affects this risk. So it's getting better, but it's still stubbornly hovering around 2% of patients. Other things are getting better because of better devices, leads migrating, moving out of the position over time, fracturing and needing replacement, erosion through the skin. This category is really getting better because of better hardware choices that have been available now in the last 5 or 8 years. So that's what I'm going to say about kind of the standard DBS treatment. We obviously have time for questions later, but I want to spend the last part of these comments really talking about what are the frontiers in DBS for dystonia. What are the things we're really excited about investigating now to improve this therapy and understand it better? So here's 3 that I've listed. One is, the brain circuits that drive the disorder of dystonia remain very mysterious. There's theories, there's been a lot of, studies of this, but we still don't have a good handle on what actually is going on in the brain in dystonia that leads to dystonic movement. So we want to better understand the electrical abnormalities, the brain cell patterns of discharge that lead to abnormal muscle contraction. The second thing we want to do is really understand how deep brain stimulation treats these problems. And part of my motivation in this whole field of electrophysiology is when we first started treating the children with isolated dystonias, the ones who do very well if you get DBS in them as children. We have this very remarkable therapy that can have enormous benefits in that subcategory of dystonia. We were doing this, had no idea of how it worked. And it's just a kind of a fascinating thing to do this remarkable therapy for that category of patients, not everyone, and not know how it works. So that's a big motivation. We want to understand it. And then we want to use the knowledge of these first 2 points to improve deep brain stimulation and develop what's often called adaptive DBS. So the analogy for this would be heart pacemakers. And remember, DBS devices are basically brain pacemakers, and they evolved from the earlier technology of heart pacemakers. So when heart pacemakers started in the 60s, they just paced the heart at 70 beats per minute, didn't respond to anything going on. Then they got more sophisticated and would sense abnormal heart rhythms and intervene when needed, would be flexible and adjust to changing needs of the organ. So now with deep brain stimulation, we are exactly where heart pacemakers were in the 1960s. The standard therapy is stimulation that is always on until you, with your patient programmer or the neurologist, changes it, manually with a programmer. It does not change automatically. And so it won't respond automatically to changing brain needs. And we really want to develop devices that are responsive to changing brain needs, because every brain disorder fluctuates. This is especially true in Parkinson's and psychiatric disorders, but it's true in dystonia as well, that you have times that are worse and times that are better, and you really want to deliver what you need when you need it. So thinking about this topic of adaptive DBS, that is DBS that adapts automatically to changing needs, there are several types of signals that can be used as measures of the severity moment to moment of the condition, and then use that as the control signal for adaptive DBS that can automatically increase or decrease stimulation levels. And there's a few categories that one could imagine using. One is shown here, and the one that I'm most interested is actual brain recordings, where you find signals in the brain that reflect the severity in real time of the problem and guide the amplitude of therapy. One could also imagine peripheral monitors that could feed back onto a device electronically and auto-adjust it, such as EMG, electromyograms. You could have a sensor on, say, a neck muscle that was active, and actually use that wirelessly to feed back on a device. Or you could use a sensor like an accelerometer on a wristwatch style in someone especially who had a tremulous form of dystonia, and use that signal to drive deep brain stimulation. So those are some of the ideas for adaptive DBS. And this is kind of how it works. You would have a special type of pulse generator as the control unit, battery unit of DBS, which now not only delivers DBS therapy, going from pulse generator to the brain, but also senses brain activity, bidirectional. It goes both ways now, and that's used within the electronics of the device to auto-adjust DBS. And one of the most exciting developments to me in the world of DBS is now the availability of new implanted pulse generators that do more than just deliver a constant therapy, but they sense brain activity and can, in principle, when we figure out exactly how, use that for adaptive DBS. And this is just a picture of 3 of the recently available types of pulse generators that incorporate brain sensing. And there's multiple companies that make good DBS devices. At this point, the only company that's really done a lot with brain sensing and adaptive stimulation is Medtronic. So I don't want this to be necessarily an advertisement for Medtronic, but they have been innovators in this sensing area. And hopefully some of the other companies which have excellent devices will look at this and adopt it as well. The first generation sensing device from Medtronic was an investigational only device. It was never commercially sold, Activa PC Plus S. That's no longer made. One that we are very excited about, which is investigational only, is so-called Summit RC Plus S, and I'll show you a little more about that. This is a very powerful tool for understanding dystonia and improving DBS. It does a lot of unusual things. It can be used to stream wirelessly data from the brain to an external computer over a distance by Bluetooth to a small computer while patients are going about their normal activities. And it can do this for many hours. It can do this during sleep. If patients carry the receiving computer with them, you can do it outside, driving around. You can live your life streaming brain data, and it is rechargeable. So you can, the current drain that takes from the sensing component is not a concern the way it would be with a non-rechargeable. There's other things that make this investigational device extremely powerful that I won't go into, but details of how we program it make it very, very flexible. Now, recently Medtronic came out with its first commercial that is not investigation only stimulator device that does incorporate sensing. That's called the Percept. And this is, we're very glad it's out. It's a big advance in DBS. It does not have the extremely powerful chronic sensing for many hours capabilities of the RC Plus S device. So I'll tell you in a few minutes about our study with RC Plus S. RC Plus S is going away pretty soon. It will not be, it's a limited program, investigational only, kind of to understand brain circuits and understand DBS, and then move on to these less complicated, sensor devices that aren't quite as capable, but hopefully we'll learn what we learned from the very powerful investigational devices to use in the new devices. So I want to just tell you a little bit about our study of brain sensing and adaptive DBS and dystonia. It parallels our similar program in Parkinson's disease. We have regulatory approvals from the FDA and our Human Studies Committee to use this powerful investigational sensing generator in Parkinson's and dystonia. There's a very specific eligibility to participate in one of these studies, though. It's important to know this. So number one, the main one is that someone who wants to be in this study at UCSF of brain sensing already should have the indications for deep brain stimulation, the standard clinical indications, significant disability in spite of best medical therapy, Botox therapy, and be interested in having deep brain stimulation, and should not have had prior neurosurgery. And at this time, we are enrolling patients in this particular study with RC Plus S who are up de novo new DBS units. There actually are studies with the Percept that are going on in Parkinson's and eventually dystonia, where you can participate with an existing device, just having your pulse generator upgraded. But the one I'm talking about right now is for new DBS candidates. So what we do in our study, and we designed it, the devices are provided at no charge by Medtronic, but they didn't dictate the study. We designed it and had the study funded through National Institutes of Health. So patients who are DBS candidates are implanted with the standard basal ganglia leads, like globus pallidus leads, or another target, subthalamic leads, just like they would be for regular DBS. But we do an extra thing. We put an extra sensing electrode through the same surgery as the standard leads, but just slipped over the motor cortex of the brain, the surface of the brain. And this sensing area is, we think, very important for understanding like what's going on in dystonia and how DBS works. So in this study, you get a little bit of extra hardware beyond what you would get in standard DBS. Then in our study, we have people after implantation do this wireless streaming of brain data from both the cortical site, the surface controller of the motor system, and their deep lead in the basal ganglia. We do have them do that for a few days before we activate their DBS unit. We study the signatures of the abnormal movements, which we think are going to be personalized, a little bit different for each person. And then we use those personalized electrical signatures of their dystonia to try to test adaptive deep brain stimulation, that is make the device amplitude vary according to brain signals to make it adaptable. This is kind of just a drawing from our medical illustrator, Ken Probst, which sort of illustrates what we're doing. This is from a publication that we just have out on this technique. But so this is a drawing of one of our patients with both the deep electrode and then this little cortical paddle sensor that's slipped in through the same hole that we make in the skull and then cover with this skull cover, vertical cover. These are attached doing the usual wires tunneled down the neck, just like in standard DBS, to RC+S investigational generator. And this communicates to a small sort of iPhone-sized external communicator that has to be within a few feet of the patient, usually just worn or put in the pocket like an iPhone. Then that Bluetooths over up to 12 meters to a small Windows-based computer. And we get very, very high resolution signals. This is just an example of some of the cortical signals, the so-called electrocorticogram, and then the somewhat smaller signals from subthalamic nucleus and globus pallidus. And then we can stream a lot of those data. One of the exciting developments in this field, as I mentioned, we're trying to correlate with these chronic brain recordings. We want to ask the question, so if a patient is, say, doing badly, having a bad moment with their dystonia, what is going on in the brain at that moment, and what is going on when they're not so symptomatic? That will help us decode what are the brain physiology involved in dystonia. But to do that, we need to be able to monitor people at home very quantitatively for their degree of abnormal movement. So this is an exciting technology where we can use video of a patient that can be in their home, that can make these little stick figures by basically machine learning techniques in a computer from a video, and plot out the exact angle of the neck, for example. And so quantify in cervical dystonia or neck dystonia exactly what the position of the neck is. And then if you have hours and hours of those data and hours of brain data, you can find out what are the brain signals related to the abnormal postures. That's the idea, one of the ideas of this study. There's an animation that's about 3.5 minutes that was made for one of our recent publications that I'll try to play that just summarizes this whole concept. And then that will be, I think, just about the end of my remarks here, and we can open it up. So let's see if this works to play it. It's got a little bit cheesy music in it, which I apologize for, but it gives the idea of what these new devices are for. Now I've covered up my area here. Okay, let's see. We tested this before, but let's see if it. Whoops. Did I mute that? Did this stop playing, Martha?
Yes, it did.
All right, there we go.
There it goes.
What if we could recognize and stop disease symptoms based on abnormal brain activity? Could we provide better, custom treatments for people suffering from Parkinson's, epilepsy, severe depression, or other neurological disorders?
Such as dystonia.
Currently, some of these conditions are treated with deep brain stimulation, or DBS for short, which delivers constant electrical stimulation to the brain. However, studies suggest an adaptive DBS device that stimulates only when needed would be more effective with fewer side effects. Therefore, researchers at UC San Francisco are seeking to accurately identify abnormal brain activity that corresponds to disease symptoms. They report the first human use of a DBS device that can also analyze a person's brain activity continuously over many hours, even days, at home. Previous devices were limited to recording brain activity in a clinical setting, tethered to a computer and for short durations. In the UCSF study, volunteer participants being treated for Parkinson's disease were implanted with the new device. brain activity was recorded in the months after surgery as they went about their normal daily routine. The subjects also wore a wrist monitor to track movement-related Parkinson's symptoms without the need for constant observation by a clinician. By developing an algorithm to decode this massive real-world dataset, the researchers identified changes in an individual's brain activity that corresponded to movement problems like slowness or an inability to walk. Using data from multiple locations in the brain, the algorithm successfully identified abnormal brain activity and symptomatic episodes in real time, matching the movement data collected by the wrist wearables. The researchers further showed that the device could deliver personalized adaptive DBS treatment at home, such that stimulation started when motor symptoms were detected and stopped when symptoms subsided. This report represents a new milestone in identifying personalized brain signatures that correspond to disease symptoms. Now that designing personalized stimulation strategies is possible, the next step is to test adaptive DBS in a formal, randomized clinical trial. This technology has the potential to advance our understanding of abnormal brain activity underlying a variety of conditions, leading to personalized stimulation therapies for not only Parkinson's, but also other neurological conditions.
Okay, well, thank you for listening to that. That was made for our first publication on this brain recording adaptive stim technique in 5 patients with Parkinson's. But we have exactly the same protocol open for dystonia. We've enrolled 2 patients so far. We're really looking for a few more while the RC+S program exists. And I think we have a really remarkable opportunity in the next year or two to enroll some more patients and really figure out what is going on in the brains in dystonia, how DBS is working and improve the therapy. That will be possible also with devices like the Percept in the future, but the RC+S program just has a uniquely powerful tool for many reasons. So for people who are considering DBS and might be interested in a study like this, or know people who are, we're happy to inform you about it. We actually have a brochure. I won't go through everything now, but there is a brochure that just goes over, eligibility, who's eligible to participate, and what the basic idea is, and what's required. And I can send that to you, Martha, also in case you people are interested in that. So I think I'll stop there and open it up to any discussion or questions about any of these topics.